Welcome to session 4 of RIO 2024, a United States Focus. In this session, the topic will be enhancing safety and efficacy in atrial fibrillation. And in keeping with our theme of pulse field ablation, we'll hear about a case of variable loop guided PVI. We have refreshed our panel, and I would like to welcome a new panel with Dr. Rodney Horton from Austin and Oussama Wazni from Cleveland. Welcome, gentlemen. Presenting this case will be our colleague and friend, Professor Moussa Mansour from Mass General Hospital. Moussa, go ahead and show your case for us. Thank you.
Good morning, everybody, and thank you, Brad, for the introduction. And I would like to thank Radcliffe Cardiology, Rhythm Intervention Online, and Dr. Nair for inviting me to present this case. This is a case, as Brad mentioned, of a variable loop catheter for pulse field ablation for atrial fibrillation. I'm going to tell you what we're doing and what we're already doing in this case here. We started the case by creating a map of the left atrium, is an it's a voltage map of the left atrium. The catheter that we will be using, which is coming up now, it is capable of voltage mapping and ablation. But the reason we did the first phase using a penta-ray catheter, as you showed, because this was a part of the Polaris study, which is an IDE study. And we wanted in the first few patients in the study to compare the mapping ability of this catheter to mapping only catheters such as a penta-ray, which have a maybe higher fidelity of treatment. So this catheter, as you see it there, is a circular catheter. And when the electrodes are 10 of them, when they are in yellow, meaning they are in the idle mode, when they flash in red, that's when one application is performed. And as you see the catheter now, it's in the ostium of the left superior pulmonary vein. And each application consists of 3 pulses of pulse field ablation, which it delivered over the span of 30 seconds. And the protocol for the ablation is to perform one ablation in at the ostium of the vein, rotate the catheter a little bit, perform another ablation, and then move the catheter outside, which you will be seeing in a second, to get the ostium of the pulmonary veins. So this catheter this procedure was performed as a part of the Polaris study, which is an IDE study, looking at the efficacy and safety of this catheter for PVI plus posterior wall ablation. This catheter just got approved by the FDA about 1 week ago, but this procedure was performed as a part of the Polaris study. And as you see here, the catheter is fully integrated with the electroanatomical mapping system. It has it has a feature called TPI, which is tissue proximity index, which allows you to know if you're touching the tissue or not. So I will stop for a second here, take a question or two from the panel, and then I will continue with the case will continue to go on, but I will take a question or two if there are any.
Yeah, thank you for taking a pause. Rodney, any comments yet? I don't think I can hear Dr. Horton.
Sorry, I was muted. So, Moussa, I was going to ask, how heavily do you rely on intracardiac echo to confirm contact with this technology? Or can you rely entirely on the contact indicators through the mapping system?
Yeah, I think you need both. This catheter is based on the CARTO platform, which, historically they have a good integration system, and what you see on the map is pretty much, relatively accurate. But I think the echo is important. And we look at the echo to see if you're deeper in the vein that you expect, if you're touching or if you're not touching. Being deeper in the vein with pulse field ablation, as you know, it may not be that important, but more so for contact, I think it's important to use ice. I just want to stop for a second, Rodney, here, and show this feature of the catheter where you can activate only half of the electrodes. So you see the catheter is not going in full, like around totally, it's a little bit wedged. So part of it, the posterior part of the catheter is deeper in the vein than the anterior part. And this is one example where you may not want to ablate from all the 10 electrodes. So you can choose only the anterior electrodes to ablate from, which were more proximal, and don't ablate from the posterior electrodes.
Can you be more specific? Are they bipolar pairs you pick, or unipolar? You pick each individual electrode?
No. So you can eliminate 4 at a time, and these 4 have to be consecutive. So you can eliminate from, so it's 1 to 10. You can eliminate either from 10 to 7 or 1 to 4. Or you can eliminate electrode 1 and 10, which is the distal more electrode. So the electrodes that you can eliminate should be consecutive.
No, since you're killing this, I'm going to ask you now, because let me just quickly finish the comment. It kind of makes a coin slot orientation, this catheter at times. Can you talk a little bit about that compared to the other PFA catheters, and how you avoid that getting, I think, flush with the ostium?
Yeah. This is not an over-the-wire system, correct? So whenever you're not using an over-the-wire system, the catheter may not be face on with the vein, especially when you're dealing with a small vein. So what you deal with that the same way you're seeing here, and depending on, we see which electrodes are touching, and then, like for example, now all of them are touching. The one before, which is the ostial lesion, they were not, the posterior one were more distal. So this will give you significant flexibility of which electrode to ablate from.
Oussama,
along the same lines, I was trying to. Sorry, Brad, but I think it is just along the same points you were raising, Brad. Is that I think though with this design, what we can do, and I was in the study, is we put it into the vein, expand it, and then when it's round, do something, very close to the ostium, or maybe even distal to the ostium, and then try to lay it flat on the rest of the tissue. Is that something to consider, Moussa?
Yeah, I mean, you can do that. We did that, as you saw, in the superior vein. And the inferior vein was such a small vein that maneuver you're describing could not be done. So, you're going to be, with all circular catheters that are not over the wire, you will be in a situation where the shaft of the catheter are going to be totally aligned with the long axis of the vein. And I think because of the fact that you can decide which electrode to ablate from, that will give you enough flexibility to overcome that situation if you end up encountering it. So just want to stop for a second here from question, and then I will show you what we did next. After the pulmonary veins, we moved to the posterior wall, and this is again part of the protocol of the Polaris study. And you see the catheter sits flush with the posterior wall. It's working well. And I do the posterior wall. I don't do the veins and then move to the posterior wall. I find it a little bit more efficient to do the veins and then keep going more posterior, and then do the posterior wall, and then go inside the right veins, as you see here.
In the Admire publication, they talked about the results in patients who had ultra-high density mapping before and after, or just using this catheter to map afterwards. What has been your workflow or thoughts about using this to do a post-ablation map?
So I think you can do I know you can do a whole case with just this catheter if you're dealing with an ablation of a fib ablation. The electrodes are little larger than the electrode on an octaray or pentaray. So if you're mapping an atypical flutter, for example, I'll probably pull another catheter. But if you're doing a fib ablation, whether it's paroxysmal, where you do the veins and you want to get a voltage map before and after, this catheter is more than enough to provide you with this ability. So it can be done the whole, and we compared voltage map compared with obtained with this catheter with voltage map obtained with higher density catheter, and you get very similar results. So it's more than adequate to get you anatomy and voltage map which I believe is important. It shows the versatility of this catheter. It's one catheter, single transeptal.
Yeah.
It goes through an 8.5 sheet, deflectable sheet like an Agilis, Visigo, or VersaCross sheet. So it simplifies the procedure significantly.
And it's integrated with the mapping system.
Correct.
Yeah. Rodney, any thoughts at this point?
So I have one question. So Moussa, when you were in the left inferior pulmonary vein and you elected to turn off 4 of the electrodes because those 4 electrodes were deeper in the vein. So I just wanted to, pick your brain on your thought process. What was the reason for turning off those electrodes? Was it injury to the PV, injury to the esophagus, potentially more hemolysis? Just what prompted you to turn off those 4 electrodes?
Yeah. So, we know pulse field ablation does not cause injury to the pulmonary veins. And I just don't like ablation or a place where I don't need to ablate. So if we want to pick one of those things that usually I think about, it's probably hemolysis. I watch the number of ablation carefully that I put. And also when you have a catheter deep inside the vein, I'm not sure if you get any more heating than you would get from a proximal place. So it's not a place that I needed to ablate. And again, this catheter, you can use it. Go ahead.
No, I wanted to just expand on that question because it's a question that is really true for this approach that we use for all the PFA systems. So in the past, the goal was to isolate the vein. Now we're often ablating the vein and isolating the vein, and we give lesions in the vein, antral, osteal. Oussama, what do you think about all of these ideas? Why can't we just use them at the ostium? Theoretically, we should be able to create antral lesions and not have to go into the vein.
Yeah, so no. First of all, I want to agree totally with Moussa. I mean, I, like him, do not like to just ablate just to ablate, even if it's relatively very safe and won't cause harm, because you never know. I mean, again, hemolysis, and then we still have to be cognizant and thoughtful of the way we do it. Now, the other aspect of ablating in the vein is something that's important to me, because now we're gonna, in some patients, we will close the appendage. We don't want to go too deep in the vein and be too close to, especially the left superior, too close to the area where the Watchman, for example, or a device, left atrial appendage closure device will be. So no, I totally agree with Moussa. And what I was saying before is that if it is hard to place it at the ostium, another way to do it is to go into the vein and pull it back as proximal as possible. And then, because it's circular, and we know that, yes, veins are not circular, but at least we can open it up so that we, with the tissue proximity indicator, have an idea that hopefully most of the electrodes are in contact, and then deliver release. That was
So I just want to make a point. We moved now, but before, if you see here, so I was ablating here earlier, and I removed all the proximal electrode because they were just floating. So here is another example where it would be useful to remove some of the electrodes. So if you're in a place where half of the electrode are just floating and you don't want to cause hemolysis, you can remove them.
Yeah.
Yeah, I think that would be the most common reason to consider doing this, is if you have electrodes floating over the ostium of the vein.
Sure. So as you see here, this is
Tell me a little bit more about the catheter.
So one thing before we do that.
Sorry, that's a lag. Go ahead.
So this is an area where I usually focus a lot of attention on. This is the antral part of the right veins, mostly the right superior pulmonary veins. More than the other veins, the right superior pulmonary veins have usually a very big funnel-shaped atrium, a funnel-shaped ostium antrum that goes all the way, significantly back on the septum. And I'd like to ablate that area way beyond the carina. So this catheter, a hole as a circle, you can put it across, as you see here, across that antrum of the right vein, and you can ablate it. And I think this area is important, and I do it a lot, and it is easy to do with this catheter. So it's, for example,
can you tell us a little bit more about this catheter?
Yes.
So you talked about
this.
Do you vary it? Yeah.
It's a lot. So as you see here, it's a constant change in the loop, depending on the size of the vein, depending where you are on in the atrium. On the posterior wall, I usually go full. I will do it max, and on the posterior wall, I do the lesions superimposed like an Olympic ring sign. So
rings.
Usual rings. So it's about maybe 30 or 50% overlap.
Is this an irrigated catheter, and what kind of prep is required before you place it?
Yeah, it is an irrigated catheter. It goes and the fluid is through a pump. So it's a fast procedure. So if you want to talk about the benefits of this catheter, you know, it's versatile. You can use it for the pulmonary veins. You can use it for the posterior wall. You can use it as a regional ablation catheter. For example, you do the antrum of the veins. You can select electrodes. You can. It is same catheter used for mapping and ablation, and it has tissue proximity indicator, and it's integrated with an electroanatomical mapping system. So these are all features, beneficial features with this catheter.
Are you doing any phrenic pacing with the catheter before you deliver?
It's part of the study that we check that. No, not before you deliver. And we did a very large number of these procedures with this catheter. We never seen any. It's our in the Polaris study. We didn't. You know, I mean, I don't want to talk about it. The result is not out, but we have a huge experience, including the Admire study, and we haven't seen phrenic nerve injury. But what I do is I pace at the beginning of the procedure and at the end, as to just to document that the phrenic nerve still work.
In the last session, the case was done with an esophageal temperature probe, which we've never considered using for any PFA cases. Rodney, do you use a temperature probe at all for any PFA systems?
No, we don't. We obviously, and I'll show later today, we do for radiofrequency, obviously thermal type ablations. It's not necessarily essential, but it's become kind of standard, at least in the US. But for PFA, we never have.
Oussama, are you doing anything
we haven't
in the esophagus to measure temperature?
No, not recently. Now, in the study, we did put an esophageal temperature probe just to see if there's any increase. I mean, there's slight increase in temperature, but since you mentioned it, so why was there a temperature probe in the previous case? I wasn't listening at that time.
It was a different PFA system, and it was part of a study, but I just wondered how your practice was at this point. I don't put one in. We did obviously for cryo and RF.
Yeah, no, I think.
So do you want to?
I don't think there is a reason to. Moussa, you are the most experienced with this. Is there any reason to consider that?
No, I mean, neither was this nor anything else. Between all the PFA catheters, and we used all of them, I never used a temperature probe in a single case. I don't know if it causes even any harm or anything. So I don't think it's useful, and I don't think you need it.
How about the use of a coronary sinus catheter now that we have PFA systems? I've started not using one for PAF cases where I don't anticipate running into any atrial flutters. You have a CS catheter in here. You think there's much value anymore to a CS catheter?
When it comes to that, I'm old school. I still do full EP studies on every patient coming for an EP procedure. I'd like to know that they don't have an accessory pathway. I like to pace if the patient slows down with some vagal maneuvers. So not maneuvers, some vagal from ablation. So I don't think I've done a single AFib case without a CS catheter. I mean, listen, it's good to be minimalistic and efficient, but frankly, that's my opinion, and hopefully it doesn't come out too strong. I really don't think you should do this procedure without some catheter for recording from in the atria somewhere, and the CS catheter gives a lot of information.
Well, it's not too strong. But
Well, aside from pacing,
What did you say?
yeah, if you really wanted to, you could pace from
in
the.
a long time. Yeah.
You Oussama, you said you use it or you don't? Yes,
No, I do not use it. I prefer not to use it unless I know that I have a flutter or something like that.
What about Rodney?
Yeah, so it's an interesting question. I have done cases with only fluoro and a PFA catheter. I'm a little old school, and I feel a little bit kind of naked in doing it that way. I do agree with you that for someone who's purely paroxysmal, so I agree with Brad, in a purely paroxysmal patient, you could make a pretty strong argument that it doesn't add much and it simply adds cost and time and that sort of thing. This is kind of a big, PFA is just a huge paradigm shift in how we think about things. So esophageal temperature suddenly becomes somewhat irrelevant. We focus on different things than what we did with radio frequency for 25 years. And so all of these were basically just reinventing the wheel to some degree with how we manage these things. And we can learn that, gosh, you don't even need a recording catheter. And you know, being trained 30 years ago, I bristle a little bit at that because I still have my original EP roots, but yeah, kind of like Moussa was implying. But is it absolutely necessary? Well, probably not for some cases. And the question is, when do you need to do it? When do you get caught by surprise and you realize, oh gosh, I don't have enough information and I'm out of my depth and I need to put something in. So, I mean, I think as long as you're willing to go back and sort of say, okay, I was wrong, let's put in these recording catheters and figure out what's going on. I think you're fine either way. But this,
well, I always get access, but I don't put the catheter, meaning I keep the access ready. And it's ironic that I learned this not having to put the CS catheter from the master of electrophysiology, Dr. Chu, God bless him. Because I walked in one time and he didn't have a CS catheter. I was like, but Chu, you don't have a CS catheter. He's like, I don't need it in an AFib case. And then I was like hesitant and also same thing, skeptical, but then I adopted it and it's been great. But I always get access because I don't want to have to, you know, bother with the access. If we need a CS, we just float it in and do.
No, that's actually a good compromise. There are some cases where you wish you had it. I would argue that you can pace from this catheter too. If you really want to do an EP study, you can pace from any of these PFA systems. And in fact, I've mapped some flutters that turned out to be mitral flutter just by mapping from the PFA catheter. But yeah, those are very good comments. Maybe having a small sheath available soon. We have to wrap this up soon. Any other comments, Moussa, from your case?
No, so not more than we mentioned. As so, it's a versatile system, and pulse field ablation. We talked about that. 10 electrodes. You can choose any. You can choose. You can eliminate some of them if you don't need to. And just got approval in the United States last week.
Well, congratulations. I think we'll wrap this up in the interest of time. I think our panel will be staying with us, but Moussa, that was an excellent case. I think a lot of people are very excited to have a system that we've been working with for years with the CARDO system, now having an available PFA catheter. So thank you very much.
Thank you.
So please stay with us for the next session. Thank you. Thank you. Thank you, Dr. Horton, Dr. Wazni. We'll see you in the next session.